Welcome to this educational activity where Dr. David T. Rubin offers insights on overcoming current barriers to the timely and effective treatment of patients with inflammatory bowel disease. The following audio is from a video talk and certified CME/CPE activity titled A Patient's Journey Through the System: How Can We Remove Barriers to Best Care in IBD? To access the entire activity and complete the post-test, please go online to www.peerviewpress.com/JVR. A printable transcript, slides, practice aids, and other features are also available.
We're here today to talk about inflammatory bowel disease and managing patients who have these conditions, which are also known as Crohn's disease and ulcerative colitis. I'm going to start with a patient and then talk about the complexity of managing this type of patient, and also, very importantly, the role payers have in our ongoing relationship with patients and taking good care of them. This is someone from my own clinic, a 25-year-old woman who was newly diagnosed with Crohn's disease involving the last part of the small bowel called the ileum. The common symptoms of someone who presents with this include weight loss, diarrhea, and abdominal pain, usually located in the right lower quadrant of the abdomen. This young woman is of a typical age of patients who present with Crohn's disease, as they are often young, and they usually have had disease for a number of years before they actually get diagnosed. Here's a picture of what her small intestine looked like. What you can appreciate here, even if you're not a gastroenterologist, is that the bowel looks swollen, it's narrowed, and the white areas in the middle are all ulcerations. Those ulcerations in Crohn's disease represent active inflammation. The inflammation can progress, and progression of inflammation over time becomes scar tissue, and then patients develop narrowing of their bowel. The narrowing of the bowel can cause obstructive symptoms and pain, and ultimately patients like this can end up needing surgery. Patients who suffer from Crohn's disease really have a lot of symptoms and do quite poorly until they have adequate treatment. It's common for these young patients to think at first that this is just a nervous stomach, something they ate, and they are often misdiagnosed. The most common diagnosis for young people, of course, is an irritable bowel, which is not what this is. But when you see someone who says, well, I'm having cramps, I don't feel well, the most common question a doctor might ask is, are you stressed? Are you taking exams? Is this a time of the year where you feel badly? In a young woman, you might say, is this related to your menstrual periods? And so there's often a time where they're seeing healthcare professionals, but the diagnosis isn't considered. The reason that's so important is because the longer it takes to make the diagnosis, the more likely the patient is to have had progression of their disease, and the less likely they are to respond to therapy once they're finally diagnosed. So this can have substantial complications and significant morbidity to the young people who are suffering from it. Inflammatory bowel disease is actually considered a rare disease, but that's not actually the way we think about it when we take care of these people. It's now estimated that there are over 1.6 million Americans who suffer from this condition, and in a variety of different studies, we now know that it's rising in the US population and, very interestingly, around the world. It is represented as an immune disease, meaning that the bowel is active and there's immune activity and inflammation that's been triggered in some way by the environment in genetically susceptible individuals. We don't fully understand the cause of Crohn's disease or ulcerative colitis, but we've learned that we can treat these diseases quite effectively if we are able to use therapies that are currently available. We also know that inflammatory bowel disease is a very expensive condition. The most expensive parts of inflammatory bowel disease are not the medications that we use, although they are expensive. The most important and expensive parts of managing IBD are when patients have complications, like being in the hospital, having surgery, being unable to work or go to school. These are the things that actually cost the most. So if we want to think about cost-effective management of patients who suffer from these chronic conditions, we should be thinking about how do we reduce or eliminate hospitalizations, surgeries, repeat surgeries, emergency department visits, and use of therapies that are not effective for them or are inappropriate. So there are some ways that we can think about how to manage this complex population, at least until we have a better understanding of how we might cure these conditions, which we haven't done yet. The current goals of managing people who suffer from Crohn's disease and ulcerative colitis include the following. We want to return the bowel to normal functioning. But in order to do that, we have to first turn off the inflammation. That's called inducing remission. When we induce remission in Crohn's disease and ulcerative colitis, the goal is for the patient to feel as normal as possible and to get back to their normal activities. This has to be done rapidly because they're sick and we don't want it to go on for a long time. And after we successfully induce remission, we then talk about our next goal, which is maintaining that. Maintenance in a chronic condition like inflammatory bowel disease means preventing relapse, preventing progression, and preventing complications over time. And in IBD, Crohn's disease and ulcerative colitis, that also means avoiding steroids, avoiding other complications like therapy-related complications, and keeping patients well by monitoring them over time. So as we move through these goals, we recognize that if we make the diagnosis appropriately, we induce remission effectively, and we maintain remission over time, we're then able to change the natural course of the disease, and by doing so, that's where we actually end up eliminating hospitalizations, preventing surgery or repeat surgery, and preventing or eliminating disability. All of this has to be tied together, and then we can appreciate that we're going to provide cost-effective care, because by doing all these different things, we'll end up with a patient who doesn't cost as much to themselves or, of course, to society and to payers like you. Now, the strategy for managing inflammatory bowel disease has evolved over time, but we still have some difficulties in thinking about how to get patients to the right therapies earlier in their management. Our current approach to managing patients includes something that looks like an algorithm of a staircase, where patients are started on an initial therapy for induction, and if they respond to that therapy, we can keep them on that therapy for maintenance, or it helps us understand what they might need for maintenance. When patients don't respond to the first line of therapy for induction, we move up the staircase to another level. An example is the patient with Crohn's disease who has more severe disease, somewhat like the young woman in my clinic. She had significant symptoms. Her bowel had obvious inflammation, and if we wanted to induce remission and needed to use steroids to do so, which is a very common strategy, we know right off the bat that this is a woman who, for maintenance, is likely to need some type of immune-based therapy. Whether it's an oral immune drug or a biological therapy is dependent on the type of disease she has, as well as how quickly she responded to the steroids. Now, the challenge to using a strategy that you see here with this staircase approach is that in order to get patients onto the next level of therapy, in order to move patients up the stairs and get them to something that actually works effectively for them, they actually have to suffer. They have to fail one level of therapy before they can get to the next. They have to have a complication on one level of therapy before they get to the next. And most payers have policies that say you have to have failed what they call conventional therapies, which are non-biological therapies, before you can get to biological treatments or other options. This is really counter to the doctor-patient relationship. It's counter to providing care to people. And I would argue, and there's good evidence now to back this up, that it actually results in more expensive care. Because if you're waiting for complications, if you're waiting for patients to fail or to suffer before you can move up the stairs, you're actually going to incur expenses, and obviously people are sick and doing poorly while this is happening. Now, there have been a number of algorithms developed for the management of inflammatory bowel disease. The algorithms are still somewhat limited, but they emphasize a couple of points. One point is how sick is the patient currently? In other words, a patient with very mild disease, you have some more time to make decisions, and you might choose different therapies for that type of patient. And a patient who has moderate or more severe disease, and this is determined based on their labs, how sick they are, how the bowel looks, all of those factors, is somebody who you might want to start with an anti-inflammatory therapy, an immune modulator, or a biological therapy earlier. What's missing from some of these algorithms, but is definitely part of clinical practice, is thinking about a patient's prognosis. So once you understand how sick the patient is sitting in front of you, the next question that a physician must ask is how sick is the patient likely to be in the next 5 or 10 years? In other words, what's going to happen to this patient who I just met, and how can I try to prevent it? Only when you consider prognosis can you actually factor in the long-term management strategy for that patient. If you're always waiting for them to be sick enough to get to the next treatment, you're going to let them and require them to be ill most of the time until you can make other treatment decisions. So when you look at an algorithm such as the one that's proposed here, you have to recognize that there's another dimension that is missing, which has to do with prognosis and thinking long term. Nonetheless, I'll point out to you that this algorithm does allow us to skip a few of those steps that I showed you to get to biological therapy earlier, especially in patients with moderate to severe Crohn's disease, where it's been well studied to actually result in less steroid use, avoidance of hospitalization, and prevention of surgery. So getting back to our patient, let's think about what we wanted to do for her. We had a discussion with her about what Crohn's disease is, what the likely complications of the disease can be over time, and we decided that we would try a therapy called vedolizumab. Vedolizumab is the newest biological therapy approved for both Crohn's disease and ulcerative colitis in the United States, and it is a monoclonal antibody therapy that's administered by infusion. The drug targets the white blood cells in your system that are on their way to the gut to cause inflammation. So by targeting that specific component of the immune system and how it affects the bowel, it is a very specific type of therapy. In fact, it is the first therapy we had that was approved for both Crohn's and UC at the same time. And because it is more gut targeted, it ends up being an extremely safe therapy. Unlike many of our other therapies that are systemic in their action, which we sometimes do need, this therapy works only on the gut immune system and therefore has a very favorable safety profile. So in discussion with our patient, we decided that vedolizumab might be a good option for her, both based on its approval for moderate to severe Crohn's, as well based on its safety profile. The problem we ran into, which some of you in the room may already understand, was that number one, this is an expensive drug. Monoclonal antibodies in general are expensive. Vedolizumab, at least on the surface, is no more expensive than our other monoclonal antibody therapies, but these are expensive treatments. This is about $42,000 a year, and maybe it's different depending on whose market you're looking at. But in other words, we know we need to have insurance support and approval before we can prescribe it. So meanwhile, of course, remember, my patient is suffering. She's sick. She has active Crohn's. So we make our calls, we fill out the forms, we ask the payer to help us, and what we learn is that this is not approved as a first-line option for our patient with Crohn's. Despite the label of the drug, despite the conversation that I had with my patient, and despite the fact that she has good insurance, the therapy is not approved as a first-line option. In fact, the payer says you must be on an anti-TNF therapy, one of the other biological therapies, a different mechanism, one of those systemic therapies that I mentioned, prior to being able to get vedolizumab, this targeted therapy. So we go back to her and explain this is what the insurance company requires. She, of course, asks why. The payer, the insurance company, is not sitting in the room with me. I have to explain to her that this is based on their policy and the way they understand these therapies and the history they have with the company that provides adalimumab and maybe other things that I don't even know. And she reluctantly agrees to go on adalimumab. Now let me say that adalimumab as an anti-TNF therapy is a very good therapy for Crohn's disease. It is systemic, however, meaning that it affects the entire body's immune system. It targets an inflammatory protein. It's a different mechanism than vedolizumab. And it is certainly an appropriate option to consider for moderate to severe Crohn's disease. So while it wasn't our first choice, and while she has some concerns about safety related to a systemically administered immune suppressant, she agrees to go on this therapy, and we start on that drug together. So what we have essentially encountered here is a stepwise approach to her treatment. What we've learned from the payer is, despite our discussions and our preferences, we're going to have to climb a couple stairs before we can get to vedolizumab. And that staircase approach is something that we use, but remember what I told you, often patients have to be sick or prove that they're not responding before we can actually get another therapy. That is a limitation not just in the way payers manage patients, but truly the way my colleagues and I have been managing patients. So after she gets loaded with adalimumab, which means she has her first injections and then 2 weeks later some additional injections, and even has her first 2 maintenance doses, so another month goes by, She's had no improvement, not just in how she feels, which of course is very important, but laboratory abnormalities persist. So we know this drug is not working. Now, one of the ways we assess why a drug isn't working is we think about, is it that the mechanism isn't working? Is this just the wrong target by targeting the TNF molecules? Or is it because of something else, like she's clearing the drug too rapidly, or she's developed antibodies against the drug, essentially become allergic to the drug? Well, how do you figure that out? Well, you have two options. You can guess and then make adjustments to the therapy and then try to something else, or you can actually measure the drug level. There is good evidence that using therapeutic drug monitoring will tell us why she's not responding to this therapy. So I want to remind you again, while I'm doing all this, this young woman is continuing to feel poorly. She's sick. She has an inflamed bowel. She is not doing well. This takes time. Multiple phone calls, multiple visits to the office, and now we decide we need to check a drug level. What happened to the adalimumab? Is it still in your system? Or have you developed antibodies and you're neutralizing it and getting it out of your body? If it's still in the system, it would suggest that we might be able to give a higher dose, or maybe we need to switch to a different mechanism entirely because that's clearly not working. And if it's been cleared out of the body and it's not there at all, especially if she's developed anti-adalimumab antibodies, she's neutralizing the drug, then we need to go to a different drug, and we can consider other drugs within the same class where she hopefully won't develop those antibodies. So I know this is complex. That's part of how we manage patients like this, and measuring the drug level is key to doing that. What happens? Well, monitoring drug levels apparently is experimental. I'm not making this up. So as much as that might make sense to you, or I hope it did when I explained it to you just now, the insurance company says, oh, you drew her blood and sent off a drug level, that $250 or $350 charge is not covered in our policy. Therapeutic drug monitoring is now considered experimental, and therefore the patient will be responsible for that bill. Now, that decision leads to another phone call to my office, leads to my office making phone calls to the insurance company, leads to me writing a letter. There's a lot of downstream effects to decisions like this, even when we think they make good sense for the patient in the first place. And I'm the patient's advocate. I'd like to think that you're patient advocates too, in a different way. So we go back and we say, well, we obtained the results already, and by the way, this drug is present in her blood and just not working. So we need another mechanism. Can we please now have vedolizumab, a different mechanism which we wanted in the first place? The payer tells us, no, actually we require two-step failures. Now I hope that those in this room understand that now that I've explained the mechanism of adalimumab didn't work, telling us to give her another drug in the same class of the same mechanism makes no medical sense. This is not only medically inappropriate, I would argue it's an unethical policy, telling us that the patient has to go on two drugs that don't work before we can actually get to a different mechanism. Nonetheless, we have to go to a second drug. So we give her another anti-TNF therapy, and you can tell me right now what you think happened. She didn't respond to it. So after failing 2 anti-TNF therapies, after approximately 6 months of back and forth in the doctor's office, continuing to be sick, multiple phone calls to insurance, multiple letters, faxes, and other communications to our insurance company, we now are given permission to give her vedolizumab. Now, it's a nice story for me to say to you that she responded to vedolizumab and did well, but that's actually what did happen. This mechanism, which is the one we wanted in the first place, did work for her, and she was doing well with this particular treatment strategy as of follow-up when I'm presenting this to all of you. So what are the consequences of requiring patients to fail 1 or more therapies before you can get on to another level to treat the patient? You now understand some of them. The patient continues to be sick. The doctor's office has to spend more time communicating both with the patient, seeing the patient, and managing them. And very importantly, from your perspective as well, is that there's a cost to doing this. There's the cost in terms of our time, there's the cost to the healthcare system, and there are costs to managing that individual patient to all of you. Because as she got more and more sick, we had to consider whether we were going to actually bring her into the hospital. And frankly, was the extra 6 months of inflammation of her small intestine going to lead to her needing a surgery that might have been avoided if we had treated her earlier with a different treatment strategy. So there are a variety of different costs to ineffective care in IBD. This isn't always payers' faults, of course. This is also our fault when we don't know how to treat the patient or when the drugs that we use just don't work. There's still a large unmet need in inflammatory bowel disease. So we recognize that there are a variety of costs, and don't forget, of course, the indirect costs of people who suffer from these conditions who can't go to work, can't go to school, can't take care of their family members, can't do all the things that they're supposed to be doing. And so we have to think carefully not only about how expensive is the medicine we're prescribing, but how expensive is the disease if it progresses and is not treated effectively. So we've actually looked into this. How much time are we spending talking to payers in order to get approval for therapies that we're recommending to our patients, in order to communicate back when one therapy doesn't work or when multiple therapies haven't worked? In a survey that was done on the internet of a number of my colleagues, we found out that most of the people who answered the survey said that at least a quarter of one of their staff members' time, that means 25% or more of that staff member's time, was being spent communicating with insurance companies. Total. That means out of a 5-day work week, more than a full day of every week was being spent on the phone trying to communicate about insurance decisions. And that is a difficult problem. And we recognize that some of this is necessary, but who pays for that? And who pays for it when the patient calls back and says, I don't know, I haven't heard anything, or when the doctor's office gets a message back that the claim is denied and we want to appeal, or the doctor's office gets a call back and says, we never received the forms you faxed. All the things that you know happen despite our best efforts and despite your best efforts. A lot of time is spent in the doctor's office dealing with some of these communication challenges. We also asked our colleagues in this survey, how often was a delay in proving care or a specific treatment affecting the patient's outcome? And more than 50% of those who responded said that it was happening sometimes, and a small percent said it is happening often. So there is a very significant consequence to the current system of getting drugs approved and trying to manage some of these issues with payers. So there are a number of questions that we have to ask, and I don't mean ask you, I mean also ask my colleagues. The first question you should be asking, and I ask them all the time, is the physician actually recommending standard of care therapy? We certainly appreciate the need to deny therapies that are not considered standard of care or aren't approved. That is something that happens, even when the therapy looks promising. That is reasonable. So when a physician is recommending a therapy that has a label that says it's appropriate for this particular disease state, like vedolizumab is approved for moderate to severe Crohn's, it should be an allowable therapy. When it's being denied in favor of not just one, but two-step failures of a different class of therapy, it raises a lot of concerns and questions. Is this all just based on cost, or is it because the insurance company hasn't kept up with the latest therapies that are available and the latest evidence-based management? In inflammatory bowel disease, we often suffer from what I call the rheumatoid arthritis syndrome. And that's not a clinical syndrome. The rheumatoid arthritis syndrome means that you take the policies that you use for the larger disease state, RA, which also uses a lot of these therapies, and you just apply them to Crohn's and colitis. Well, vedolizumab is never going to treat rheumatoid arthritis because, as I taught you, it only treats the bowel. So here we have this therapy that you may not know much about and isn't in the part of your binders that talks about rheumatoid arthritis. So it's lagging behind in you guys giving us approval for it. It's just an example. We also have to ask questions about what are the physician's ethical responsibilities. What are my responsibilities to my patient who's sitting in front of me who's sick? My responsibility is to get her well as quickly as possible and to recommend what I think is the best treatment for her. But we can ask the question, is it appropriate for me to recommend a therapy that isn't going to be approved? Well, of course, that's a challenge that I face. I certainly have an obligation to say to the patient, we need your insurance company to give us approval before we can use it. We also have to think about what your ethical responsibilities are in terms of appropriate communication back to us, streamlining the process, and understanding the standard of care and the available evidence when it comes to therapeutic drug monitoring, failure of a mechanism as opposed to failure of a specific drug, so moving on to a different class when we need to. There are a lot of questions that you have to be answering, and we have to hold you responsible for in managing these patients with us. So I want you to understand that I realize and I acknowledge that there are special obligations and special powers that you as payers actually have. And we should outline them here today, and you should be thinking about them when you are managing patients, and I especially want you to think about them when you're managing inflammatory bowel disease patients. You have an obligation to know what the standard of care is. You have an obligation to be apprised of updates that occur to the standard of care, whether that's in the form of the latest guidelines or recent significant or landmark studies that have been performed. And you certainly have an obligation to know when there's a significant change in the way we think about safety or efficacy. When we have a new study or a new paper or a new therapy that provides a preferable safety to efficacy ratio, that is something that you should know about, because that's going to influence prescribing behaviors and decisions by both providers and patients. And I would also argue that you have an obligation to provide more transparency as to reasons for denial. Everybody understands that there's some limitations to resources, and I'm going to talk more about that in a second. We also think that you have some unique power. You can, in fact, mandate prevention. There are many different things we do for patients with Crohn's and colitis to prevent vaccine-preventable illnesses and infections, to prevent cancer by surveying them properly, to prevent disease progression by encouraging Crohn's patients to quit smoking, which makes it much worse. There are many things that you could, in fact, do to help us manage our patients more effectively. So that would lead to not just better care, but also what I would say is cost-effective care by doing such things. So there are some challenges you face, and you think about them every day in different ways. I want to outline them for you in a couple specific issues right now. First, the challenge is providing care to the greatest number of individuals, but with less benefits, because you only have a certain amount of resources to share among your population. I understand that. That's different than providing the most care to a very small number, which we would call rationing the care if we need to in different ways. You have an obligation to provide some care versus an obligation to your shareholders or others to be profitable or fiscally responsible. I do understand that. You have a necessity to embrace cost-effective care compared to embracing the newest care, which you would deem experimental and might be more expensive before it's been proven. Understood. You also have a challenge of understanding what the standards of care are versus knowing what the evidence-based practices are. An example would be that therapeutic drug monitoring. There is very clear evidence in our field that using a drug level can guide decision-making, but it hasn't made it into some guidelines yet. So how do you as a payer realize that spending a couple $100s on a diagnostic test will actually save you money in the long run instead of the patient requiring to get more and more of an expensive drug that just isn't going to work? Much more expensive to do it that way. So there's an example where those two things have to be considered. And lastly, there are some patient and provider expectations and assumptions that you're going to provide coverage. I think there's some misunderstanding about that. A patient thinks that they're going to always have coverage for what they need when they need it. And of course, the reality is that there are limitations to coverage. And that is important for us to understand more about. And of course, you live that every day. So there are many different pushes and pulls and tugs on your obligations that have to be balanced. And we understand that. But I think those can be communicated more effectively, and you can do this in a better way. I would argue that the position should be that payers have an ethical obligation to use their resources to provide the best care to the most patients. And you're all nodding because, of course, you agree with that statement. But here's how I think you can achieve it. You should be investing in appropriate expertise and education about advances in disease management. I know that you have physician experts who often review your policies after they've been written. I would encourage you for specific expensive disease states like inflammatory bowel disease to actually host advisory boards or engage key opinion leaders to help teach you more about where the field is and how certain areas can save you money if they're done properly. I think it's your responsibility to actively seek information regarding new therapies. That doesn't mean some cursory annual review of your existing policy, but rather keeping up with the field, which can be very difficult. This is where you can engage other experts to help you with this. You do have to recognize your conflicts of interest related to your fiduciary responsibility and try to have some kind of firewall that is between those. And I know some companies have that established pretty cleanly and others do not. I think that you should be providing transparency regarding your reasons that you favor one therapy or a class of therapy or stepwise failure over options to provide other treatments. If you're saying no, explain why. And I think that by providing transparency, everybody will be on the same page, even if the decision is an unfavorable or unpopular one. I also think that you should be considering funding clinical research. I don't mean basic science research. I don't even mean looking at new therapies specifically. But if there's a question about comparative effectiveness, if you're going to say that a patient who fails one anti-TNF needs to go on another one before you're going to give them a different mechanism, why don't you fund a small study to show us that that actually has any benefit? Or at least look at your claims data analyses to figure out if it actually ever made a difference. And then provide those data to clinicians so they understand that actually there's some rationale behind these recommendations. You have the funds, you have the resources, you could do this effectively. And with diminishing costs and available grants from the NIH, and diminishing resources to do some of these studies otherwise, I think that you should join the efforts to do so and to help us all. And lastly, I think it is of course appropriate for you to provide cost-effective care, but realize that cost-effective care is not just direct costs to the payers, it's downstream. And I've seen some payers embrace this very nicely and think about how can we reduce hospitalizations and surgeries and ED visits. But I think that being upfront about how we can do this together and thinking about some novel ways to do it that are not always about just treatments would be a very nice thing for you to continue supporting. So how can you provide cost-effective care? Well, first of all, focusing on prevention. You know this in theory, but we don't see it so much in practice. Coordinating care among multiple practitioners. We can't get reimbursed for the work that a nutritionist or dietitian in our practice does with our patients. That's ridiculous. This is a bowel-related disease that can lead to malnutrition, yet we can't get paid for our dietitians and nutritionists who provide very much education and important medical assessments of these patients, just as one example. You can help engage patients in decision-making and coordinated care and self-management. And I think that you can do a better job helping us spread evidence-based best practices so that individuals who are out there in practice will learn from what you provide to them and say, you know what, this payer is actually a valuable source of information and they are really in it to understand the disease state and provide me with better education. You can do so by funding CME, by providing support for other educational interventions, and by being the source of information that leads to better care and provides everyone with a better way of doing this. And I do think it's completely appropriate for you to deny. I'm not here to say you should never deny what a physician asks. You should refuse care that's inappropriate. You can educate physicians and patients when you do so, but there should be a rationale and transparency in those decisions. Now, I've already said this a couple times. I'm going to drive it home as I conclude. There is a cost to ineffective care in the inflammatory bowel disease world. The longer the patient who has this disease is not under good control, the more likely they are to suffer consequences and complications. They may actually result in not receiving their therapy in a timely manner, which means they have ongoing progression. The disease may not respond to the treatment, meaning that the treatment we've chosen is the wrong mechanism for what's going on in this individual. The patient or the provider may actually not be adherent. In other words, they're not keeping up on the therapy, they're not taking the therapy that's been prescribed, and there are many ways to understand why that might happen. One of them is because it's too expensive. Even with your coverage, the therapy may still have a copay that the patient can't afford. The other way that's important from my side of things is if the patient doesn't understand why we're using a specific therapy or what the safety of that therapy might be. And we also have to acknowledge that as in any chronic disease, inflammatory bowel disease is no exception. Chronic diseases tend to drift and tend to change over time. So the patient who's responding today may not be responding tomorrow because the disease has progressed or because they've grown, or when they get healthy, they gain weight. Lots of things change, and it requires an ongoing assessment to keep the patient under good control. And of course, when we don't keep them under control, when we take our eye off the ball, when we don't provide therapies that are effective or the right mechanism, there is a significant cost, directly and indirectly, to the patient, to society, certainly to payers. So what I would conclude with here is how we can improve care of patients together. And I hope that today I've made some important points for you to consider and improve the care of patients with Crohn's disease and ulcerative colitis. First, we can incorporate better shared decision making. That's really on my side more than yours, but this has to do with letting patients try certain therapies for a defined period of time and reassessing. You could do this too, in the sense that you say, okay, Dr. Rubin, you want to give vedolizumab, we're going to give you 6 months. Please report back to us how the patient's doing in 6 months so we know whether we should continue supporting that, and we'll help you assess whether the patient's responding and move you through a different treatment option if necessary. We should be addressing adherence issues, which means I should be addressing why my patients are afraid of some therapies. We should address misinformation, which you can certainly help with as well. And we should provide therapies that are not only available, but making sure they're affordable, even when there's a copay issue, or maybe especially when there's a copay issue. And lastly, I think that we can all be working much better together. I think that payers have some obligations to help us with more effective and smoother communications. There's got to be a better way for us to communicate back and forth and to reduce the cost on our practices. I think that you need to be more dynamic in your decision making to allow therapeutic adjustments, and you need to trust some of the physicians, especially your experts. And lastly, you need to update your policies embracing new therapies and new approaches so that we can stay on the cutting edge while we fight these diseases together. I want to thank you very much for your time, and I'm looking forward to improving the care and the lives of patients with Crohn's disease and ulcerative colitis. Thank you.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening to this activity. To view the rest of the CME CPE activity, download materials, and complete the post-test for instant credit, please go online to www.peerviewpress.com/JVR. This activity is supported by an educational grant from Takeda Pharmaceuticals USA Incorporated.